Well, hello, everyone. My name is Dr. Joseph Mikhael. I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation, and I'm a professor at the Translational Genomics Research Institute in Phoenix, Arizona. It's my pleasure today to try and give you that balcony overview of the great abstracts that came out at ASCO and EHA 2022 that relate to multiple myeloma. I'm just going to give you highlights of key areas. I can't get into too much detail with each one, but we're going to look at four major sections. We're going to talk about frontline therapy. We're going to talk about relapse therapy. We're going to talk about the new bispecific agents that are about to join us. And then we'll have at the last chapter, a little look to the future of some other newer things that are coming. With respect to frontline therapy, perhaps the most significant abstract presented at both ASCO and EHA was the late breaking abstract that actually became a plenary abstract at ASCO. Plenary meaning only 4 abstracts in all of cancer are selected for this plenary session, was the determination trial. This was a US trial presented by Dr. Paul Richardson, and I actually had the privilege of being the discussant for that trial that compared as a big phase 3 randomized trial patients to receive RVD or Revlimid, Velcade, and dexamethasone plus transplant and then lenalidomide maintenance to just getting Revlimid, Velcade, dexamethasone followed by Revlimid maintenance. So really trying to evaluate the benefit of stem cell transplant now that we have these newer agents. It was very similar to a French study that was recently published and actually had a similar result. And the result was this, that when you had a transplant, patients stayed in remission over 20 months longer than those that did not have the transplant. So it really speaks to the fact that transplant is still very effective. Interestingly, however, when over the long term patients were followed, there was not an overall survival advantage, meaning whether patients had a transplant or not, there wasn't an overall survival advantage. And this led to a lot of discussion that is not easy to summarize, but in brief, it still speaks to the fact that transplant is helpful in myeloma. It does perhaps give us a choice of not necessarily always doing it up front, that it could potentially be done later, but that really most importantly, it has to be a discussion between the healthcare team and patients, where we have more choices than ever in myeloma. And that really is maybe the greatest theme of all of the abstracts, that we are increasing our choice all the time. There isn't just one way to treat myeloma. The last comment I'm going to make about the determination trial, as many of you know, I lead the diversity efforts at the IMF and our Empower program. And one of the challenges in health disparities we see is the lack of representation of African Americans in trials. But this trial was an exception. Remarkably, there were 19% of individuals who self-identified as Black or African American, which really reflects the true population. We expect about 20% of all myeloma patients are indeed Black or of African descent. And so this was remarkable because typically that number is much less, and I want to commend the investigators for that. There was one other frontline study that was, I think, of significance, was a French study that looked at adding daratumumab to carfilzomib, Revlimid, and dexamethasone, or DARA-KRD, in high-risk patients. Patients who have certain high-risk features, we know it's tougher for them to respond to the treatments that we have. And so they tried to combine in this quadruplet, arguably the best quadruplet of drugs we have right now in frontline myeloma. And they did see quite a deep response with this. Obviously, we'll have to see in the long term what happens. But another key lesson we learned from that study is that when we use these 4 drugs together, it can be a little bit difficult to collect stem cells if we wait for 6 cycles. And so they recommend that we do this after 3 cycles. So great things happening in frontline myeloma. Relapse myeloma was really, of course, where perhaps the bulk of abstracts were presented. And so in relapse myeloma, we have a whole series of abstracts that were presented. The first of which were a series of abstracts using belantamab mafodotin, that antibody drug conjugate, as we call it, that drug that hooks onto BCMA and then kind of has a backpack of a toxin that it drops into it. It's been a very helpful drug to us, but it has been having some troubles with causing what we call keratopathy of the eyes that can lead to some blurriness of vision and dry eyes for patients. So there were some studies that evaluated belantamab at a lower dose when combined with other drugs. In particular, a drug that's called a gamma secretase inhibitor, which can actually make the drug more effective while using a lower dose, which could then hopefully reduce that keratopathy. And sure enough, that's what they saw, that the drug maintained, this combination maintained the efficacy with good response rates, but not so much keratopathy. And we're seeing a similar trend. It's being combined with drugs like lenalidomide and even pembrolizumab. The other huge area of study in relapse myeloma was in CAR T cell therapy. We have 2 approved CAR T cell regimens right now, and we're seeing more and more being developed. And I'd summarize the CAR T as follows. Firstly, we saw in a Spanish study in Europe, almost like a make at home or make within the academic center CAR T, which was really impressive instead of necessarily having to send it out to a different manufacturing location. And they could even make a second dose or a booster dose later. So we may have better ways of creating CAR T. Secondly, we saw CAR Ts used earlier in the disease course. Right now, people have to have 4 prior lines of therapy, but in the CARTITUDE-2 study, we're seeing the benefit of CAR T even in 1 to 3 prior lines of therapy. Thirdly, we saw CAR Ts using different ways of making the product, it's a really complicated process in which we do the manufacturing. And as we learn it and upgrade the way we do things, I think we're going to be able to produce more effective CAR Ts, or CARs that last longer, if you will, that have more fuel in the tank to last longer. And then lastly, we saw some CAR Ts that attach to a different part of the myeloma cell. Historically, we've used BCMA-directed CAR Ts, but now we're seeing some CAR Ts that actually can hook to different targets, including one that is called GPRC5D, which is really quite heavily expressed in myeloma. And this, I think, is going to be a particularly important feature both for CAR Ts and for the next section that I'm going to describe, bispecifics, because it gives us a chance to come at myeloma in different ways. And we've learned over the years that it's always good to attack myeloma in a different capacity. And that brings us to our third chapter. Chapter 3 is on bispecific therapies. And these, almost all of us in the myeloma community believe, are really going to change the way we treat myeloma. These drugs are called bispecifics because they have one arm that hooks onto the myeloma and another arm that reaches out to a local immune cell, usually a T cell, and now we're seeing some new ones with natural killer cells, to engage it to destroy the tumor. So instead of in CAR T, where we have to take T cells out of a patient and manufacture them and wait several weeks and give it back, we can just give this bispecific drug directly and help destroy the tumor. We saw updates for teclistamab, probably going to be the first bispecific that we're going to have with really impressive response rates over 60%. We saw another bispecific that targets BCMA, elranatamab, which now they have an interesting step-up dosing process to reduce the risk of what is known as cytokine release syndrome, or the reaction that people can get when they receive a bispecific. There was another, the Regeneron product 5458, that also was demonstrating really lower rates of cytokine release syndrome, so that this drug could be more easily tolerated and maybe ultimately given in the community. And then we saw a couple of bispecifics that target that new a target that I mentioned, the GPRC5D, which is talquetamab, and then another Regeneron product, the RG6234 drug. So really impressive to have this many drugs of similar capacity, but each of them unique in their own right, being developed at the same time. In fact, in over 20 years of myeloma, I've never seen this many drugs at one time being developed, so it's very exciting. And then lastly, in the final chapter, just looking ahead to the future. That's not it. If that were it, that would still be very exciting. But we saw some updates to other drugs that we know are in development, drugs like iberdomide, which is leading a new class of drugs similar to, but not identical to, the IMiDs, or drugs like lenalidomide and pomalidomide. We saw a kind of a new take on an old friend of an old drug called interferon, but a new way of delivering it with a drug called modakafusp. And that really could be an impressive way to treat myeloma that's heavily pretreated, even in patients that have had a lot of BCMA treatments beforehand. And then lastly, we saw the drug isatuximab, which is a CD38 antibody that we now use, that's only given intravenously, that we can potentially use subcutaneously with a new form of this drug. So it's really quite impressive what's happening in myeloma right now. I haven't even covered the whole gamut, but tried to give you this overview that whether it's in frontline therapy, in relapse therapy, in CAR T, and bispecifics, and in future therapies, we're really seeing remarkable developments in myeloma that we hope are going to bring us closer to a cure, and in the interim, provide better quantity and quality of life for our patients with multiple myeloma. Thanks very much.